To start, I would like to thank you for the invitation that allows me today to participate in the class symposium addressing the topic of stem cell deficiency that is induced by the use of contact lenses. I have no conflicts of interest. We will highlight some important aspects that are related to a healthy ocular surface. And let's start by saying that the contact lens wearer, whether it be soft or hard contact lenses, that to maintain a healthy eye surface, they need to keep the lacrimal system functional unit intact. And we also want to emphasize that the use of contact lenses can produce a chronic irritation that is accompanied by neurogenic inflammation, with pro-inflammatory cytokines in the tears that may eventually promote the interruption of sensory neural impulses to the superior salivary nucleus of the bridge and interfere with the afferent pathway, which is important to maintain adequate lubrication of the ocular surface. We also want to remember that the use of contact lenses can induce mechanical changes, toxicities, releasing of mediating factors of inflammation and hypoxia, causing a morphofunctional change in the Vogt pallosides. And it's in these Vogt pallosides, especially in its crypts, is where the stem cells are to be found. Now, so that there is harmony on the ocular surface between the processes of desquamation and cell regeneration, we have the Thoft's X, Y, and Z theory, in which the X in the equation represents the centripetal migration of the basal cells that then transform into transient amplifier cells, then in post-mitotic cells, and finally in the terminal transient cells that will then desquamate. And this number, X plus Y, represents the proliferation and the migration of these stem cells, which will then divide and keep splitting and then repeating to get the answer that we need, which equals Z. And so Y stands for the proliferation and the Z for the desquamation. So X plus Y has to be equal to Z to have a healthy ocular surface, which is demonstrated with the installation of the fluorescent eye drops. And here we have an unhealthy ocular surface shown with fluorescein. So we're seeing a surface with major superficial keratopathy. Here are some aspects I want to emphasize in relation to limbal stem cells. Again, the stem cells are in limbo, in the crypts of the Vogt palisades, and they divide, and one becomes a new stem cell, and the other a transient amplifying cell, and it makes the centripetal migration and becomes a postmitotic cell, and then a terminal transient cell and desquamation. Therefore, the maintenance of a healthy corneal epithelium under normal conditions and during wound healing takes place through this population of stem cells that are located in the basal epithelium in the corneal scleral limbus. Again, here we're looking at the stem cells, the transient amplifying cells, the postmitotic cells, the transient terminal cells, and desquamation. And we are seeing conjunctivital cells in green, stem cells in blue, and transient terminal cells in the conjunctiva. But the purpose is to draw attention to the territory where the stem cells are located. And this forms a territory and a microenvironmental environment that is influenced by soluble molecules, growth factors, stress, toxicities, inflammatory cytokines, and it is necessary that this microenvironment is healthy so that there is an adequate regulation of stem cells so that the ocular surface remains stable. Well, if that doesn't happen, then we are heading towards limbal stem cell deficiency. Here, I want to draw your attention to the slit lamp biomicroscopy, showing the Vogt palisades there, that are clearly visible, because the individual is melanodermic, and in the crypts of these palisades are the stem cells. And so the presence of intact Vogt palisades is a clinical marker of stem cells. Today, also widely used, impression cytology can demonstrate, for example, the presence of goblet cells in the cornea, closing the diagnosis of limbal deficiency. Also, confocal microscopy and optical coherence tomography are bringing home light to the knowledge of this specific area of study. Limbal stem cell deficiency can result from acute illnesses such as chemical and thermal burns, Stevens-Johnson syndrome, chronic diseases such as ocular cicatricial pemphigoid, irradiation keratitis. After multiple surgeries, the use of contact lenses, in addition to the topical use of preservatives such as benzalkonium chloride, and are represented by congenital aniridia and erythroderma. Here we are to focus on the use of confocal microscopy and OCT in the study of the Vogt palisades and crypts. Observe here, as we have both the studies that show the columns of the Vogt palisades, and it also shows the aspects of the crypts with their circular formations in show. We may then have contact lens-induced limbal stem cell deficiency, which is the subject of this presentation. I am posting here a series of photographs from eyeworld.org to show, for example, that corneas that suffer from a contact lens stem cell deficiency, they show loss of transparency, as we observe over here. This superficial epitheliopathy is very similar to an inverted hurricane. These materials that enter, along with vascularization, alters its transparency. And an aspect that we are going to draw a lot of attention to, which is columnar keratopathy. And by the way, this is the aspect that I am going to push now. This is a study by Dewar and his collaborators, which had already described columnar keratopathy as an early manifestation of limbal stem cell deficiency. And we can see in figures A, B, C to I that show several examples of columnar keratopathy, which are very, very visible. A, B, J, for example, these are signals of stem cell deficiency. And if you instill the fluorescein eye drops, wait a while, after 1 or 2 minutes, these staining columns are seen next to the non-staining columns, and the compromised corneal epithelium is what stains. Here we have a study that used confocal microscopy to show the columns along with the highly hyperreflexive cells that show vascularization and also the Vogt palisades with altered morphology, which is due to the limbal stem cell deficiency. Well, Let's present some published studies on this topic, and we will start with the study by Raul Martin, and he had 591 patients with myopia of minus 8.80 and standard deviation of 5 diopters. Myopias ranged from minus 1.75 to minus 21.5 diopters, and were wearers of contact lenses fitting between March 2004 and March 2005. And of the total number of patients examined, changes were found in 2.4% of patients, or in 24 eyes of 14 patients. Changes included corneal conjunctivization at daily wear of 12.5 hours, with a standard deviation of 1.8 hours, and patients wore contact lenses for 17.6 years, with a standard deviation of 8.5 years, and corneal conjunctivization was considered by the author as a complication related to the use of contact lenses in asymptomatic patients. The second article that I highlight here is that of Kim and her collaborators, and in 15 patients, 22 eyes were selected from a tertiary referral center in the period between 2007 and 2011. Here, the limbal deficiency of stem cells by contact lens was observed in 13 eyes, and in the presence of rosacea in another 3 eyes, and due to benzalkonium chloride toxicity in 2 eyes, and idiopathic caused in other 3 eyes. All eyes had a loss of limbal architecture, showed signs of verticillate keratopathy and opaque epithelium with late staining by fluorescein. The epithelial phenotype returned to normal with conservative measures in 4 patients, 4 eyes, only with lubrication and discontinuation of contact lens use. And these contact lenses were always soft contact lenses, and in other 11 patients, 18 eyes, it was necessary of 3 months of additional interventions, with topical corticosteroids, topical cyclosporine, topical vitamin A, oral doxycycline, punctal occlusion, or a combination of these treatments. All eyes evolved to be a stable ocular surface over 15 months of follow-up, and visual acuity improved from 2042 to 2026. The other work that I am going to draw attention to is Chan and Holland. They reported 12 patients, 18 eyes, a mean age of 42 years, ranging from 19 to 58 years old, and wearing contact lenses for 14.1 years with a range between 1 and 20 years. 6 of the patients, or 50% of them, had limbal stem cell deficiency, biliterary, or wearing soft contact lenses to correct their refracted errors. Visual acuity was reduced to 2078, ranging from 2030 to 2250. Eyes had verticillata or hurricane epitheliopathy, and corneal conjunctivalization and compromised epithelium had late staining with fluorescein. And what is important about this publication? All conservative treatments failed in all eyes. 14 eyes, or 77% of this sample, underwent limbal stem cell transplantation with systemic immunosuppression. And now we highlight the work of Lee and his collaborators, who report limbal stem cell deficiency in Koreans, 42 eyes of 22 patients, selected between 2004 and 2019. Limbal stem cell deficiency induced by contact lenses, 91% of patients were women at age 36 years with a variation of plus or minus 12. Myopic individuals had a mean spherical equivalent of minus 7.52 diopters with a standard deviation of 3.2 diopters. 20 or 91% of them had bilateral disease. 14 or 63.6% of them had complained of decreased visual acuity and reported the use of soft contact lenses for 14 years with a standard deviation of 9 years. The findings of 12 patients with a follow-up of 28 weeks and the standard deviation of 42 weeks, who, with the suspension of the contact lens, showed improvement in visual acuity and ocular surface were reported. Of these, 5 or 42% showed full recovery and 7 showed partial recovery. And if we compare these results of the previous study, we will verify that identifying cases of limbal stem cell deficiency earlier is associated with a better clinical response. And identifying these cases late, it may require complicated surgical procedures. In these pictures, the patients that you can see clearly show the changes in the surfaces in these figures above. And here, for example, I will highlight the figure which is known by the patient identified by the letter J, who presents a very evident columnar keratopathy. And these authors highlight the case of a 22-year-old who had been recently discovered to have worn contact lenses for 6 years, and who presents in figures A, B, and C pre-treatment columnar keratopathy, after which the contact lens was discontinued. And with the use of topical preservative-free lubricant, autologous serum, and corticosteroids, 5 months later there was a great improvement that you see in the ocular surface of this person, in figures D, E, and F. Now let's present this case given by Dr. Cesar Lipina, who is a 19-year-old student who presented hyperemia, photophobia, and discomfort associated with the use of soft contact lenses in her left eye. And this discomfort was 15 days old. And so she wore a daily use soft contact lens with a 30-day discard, and she mentioned cleaning and storing the lenses with a multi-purpose solution. Unremarkable personal and family background. Now the refractive error of the right eye was minus 7.75 and combined with 0.50 on the 150-degree axis, visual acuity 20/25, and the left eye was minus 8.75 combined with minus 0.50 on the 165-degree axis, with a visual acuity of 20/40. Here, the pictures of the left eye show neovascularization in the periphery of the cornea, easy to see conjunctival hyperemia, and this superficial punctate keratitis. And at first, as a differential diagnosis for keratoconjunctivitis in contact lens wearers, chronic hypoxia, dry eye, toxic keratitis, and infectious keratitis of bacterial, fungal, acanthamoeba, or herpes simplex origins were considered. We are always afraid in these cases of acanthamoeba. With this hypothesis, the approach was expectant, involving the suspension of the use of contact lenses and the use of lubricant eye drops without preservatives. And the patient returned in 15 days, and plus another 15, there was no improvement. Then, an infectious keratitis was questioned, so catafloxacin eye drops were prescribed every 6 hours. But before that, material for bacterioscopy and culture was collected, and bacterioscopy and culture were negative for acanthamoeba and fungi, but contact lens culture was positive for Enterobacter. After 2 months, D plus 75 days, the patient had mild punctate keratopathy, superficial neovessels were present, and 0.12% prednisolone acetate eye drops were introduced, 1 drop twice a day. And after another month, we are in D plus 105 days. The cornea was transparent, absence of keratopathy, partial regression of the neovessels, so the occasional use of the daily discard soft lens was allowed. Of course, patients who have a high refractive error do not always follow our indications in these cases. And so, this patient returned after 1 year, again using a soft contact lens with a scheduled 30-day change, presenting intolerance after 3 hours of lens use in the left eye for 2 days. And biomicroscopy showed a diffuse gross keratopathy, more intense in the upper region, thickened limbus with new vessels, and lacrimal meniscus and decreased. But look, it's the sign of columnar keratopathy. Scraping the material that showed the presence of a goblet cell in the cornea was collected, and the use of contact lenses was suspended for 6 months, and a lubricant without preservative and 0.1 fluorometholone was instituted. On return after 6 months, it had no changes, and a rigid gas-permeable contact lens was fitted, with 1 visual acuity in both eyes, and marked return. After 1 year using these lenses, everything was normal without changes. Now, what can we get out of this whole story? That between contact lenses and limbal deficiency, we have the contribution of mechanical changes due to the pressure the lens makes on the limbus, toxic factors and mediating factors of inflammation, leading to hypoxia and limbic deficiency. And so, what of the surgical treatment of limbal deficiencies using contact lenses? Look, the first proposal that appears here is the sequential sectorial corneal epithelioctomy proposed by Dewar in 1988. And in Figure A, after fluorescein instillation, a late impregnation of the compromised epithelium occurs after 2 or 3 minutes. And compromised epithelium is removed and healthy epithelium migrates to replace the altered epithelium. And with this, the central area of the cornea ends up having a normal epithelium, regaining transparency and improving vision. And we are talking about sequential sectorial corneal epithelioctomy. You may have to necessitate amniotic membrane transplantation. The yellow area on the cornea was what was left of healthy epithelium, and everything else around there was altered. And you can remove all the altered epithelium and to facilitate healing with amniotic membrane transplantation. This is what was done in these cases here, which were conducted by Dr. Renato Perez, which shows a patient who had chronic use of contact lens, which induced limbal stem cell deficiency, which then altered the epithelium and it was then removed. And then an amniotic membrane was applied, which favored the expansion of the healthy epithelium with total recovery of the ocular surface after 2.5 months. There are cases where it may be necessary to use autologous or allogenic limbal transplantation from living relatives, or allogenic cadaveric keratolimbal transplantation with immunosuppression, associated with amniotic membrane transplantation. In the scheme we are seeing, we have a limbal and amniotic membrane transplant to favor the expansion and migration of healthy epithelium for the recovery of this surface. Here we see a case of Dr. Gomez, who underwent autologous limbal transplantation with amniotic membrane transplantation to show epithelialization coming from the two limbal grafts. And here we observe an ocular surface that has recovered after 60 days from a case of chemical burn.
Depois de 60 dias, nós temos aí uma superfície ocular recuperada num caso de queimadura química. Pós-operatório de 60 dias, e aí dá para ver o transplante mostrando a expansão das células epiteliais normais até uma epitelização mais sadia da superfície ocular.
What messages would you like to leave from this presentation? Now, look at the images that we've presented before. A contact lens wearer who begins to have changes in corneal transparency, verticillate or hurricane epitheliopathy, loss of corneal transparency, neovascularization, and especially the sign of columnar keratopathy, is a partial deficiency of stem cells of the limbus, and with the suspension of the use of the lens and with clinical treatment to de-inflame the eye. And these cases are reversible, but not by making them identification and letting time run out. These changes may become persistent, and these eyes may even need limbal stem cell transplantation, as we have shown earlier. Thank you very much.